Hi, good morning, doctors. Today we are on our 18th day of reading Oxford Handbook of General Practice. I am Dr. Sesha, your study buddy, and we are preparing for this MRCGP International AKT exam together. So we are on page number 407. Today our chapter is Renal Medicine and Urology. Let's start reading. (408) Laboratory test. Serum creatinine, commonly ordered test to detect dysfunction, can be used to calculate the estimated glomerular filtration rate (eGFR) when corrected for age, sex, weight and ethnicity. So there is a reduction in GFR in association with increase in serum creatinine. Urea, commonly ordered test to detect renal function. While a reduction in GFR is usually associated with an increase in serum urea, urea may also vary independently of the GFR. Causes of abnormal serum urea are increase in serum urea more than 6.7 millimoles per liter indicates renal failure, GI bleeding, high protein diet, drugs, high dose of steroids, tetracyclines, dehydration. Reduction in serum urea less than 2.5 millimoles per liter can be due to liver disease, reduction in urea production, anabolic state, high ADH levels, high GFR, starvation or low protein diet, and pregnancy. Plasma potassium more than 6.5 needs urgent treatment. Check it is not an artifact due to hemolysis inside the bottle. Admit for investigation of the cause and treatment. So for any sample, if you are finding plasma potassium is more than 6.5 millimoles per liter, you have to check it is not an artifact. Also, hyperkalemia. High potassium levels, that is more than 5 millimoles per liter. The causes are listed in table 13.1. Treat the cause. ECG changes associated with hyperkalemia. So in hyperkalemia, there will be tall tented T waves, small P waves, wide QRS complex becoming sinusoidal. The QRS complex will be like this, supposed to be like this, but then the QRS complex will become nearly about sinusoidal and there might be ventricular fibrillation. So these are the ECG changes associated with hyperkalemia. Hypokalemia. Hypokalemia means low potassium levels less than 3.5 millimoles per liter. It presents with muscle weakness, hypotonia, cardiac arrhythmias, cramps and tetany. These are the presenting features. Both hyper and hypokalemia will cause arrhythmias, whereas hypokalemia will cause weakness, hypotonia, cramps and tetany. Causes, table 13.1. If potassium is more than 2.5 millimoles per liter and no symptoms, give oral potassium supplement. If the patient is taking thiazide diuretics, hypokalemia is more than 3 millimoles per liter, rarely needs treating. Hypokalemia, that is potassium more than 3 millimoles per liter, rarely needs treating if the patient is on thiazide diuretic. Otherwise, normal is more than less than 3. Normal hypokalemia is potassium less than 3.5, whereas the cutoff is reduced when patient is taking a thiazide diuretic. Plasma potassium levels less than 2.5 millimoles per liter needs urgent treatment, so you need to admit the patient. ECG changes associated with hypokalemia. Now it is hypokalemia. Small inverted T waves, prominent U waves, prolonged PR interval, depressed ST segment. So here there are major changes in ECG when there is hypokalemia. So there will be first, starting from the start of the ECG, there will be a prolonged PR interval. After the prolonged PR interval, there will be a QRS, and after the QRS there will be small depressed ST segment, and then there will be inverted T waves or small T waves and a prominent U wave. Hyponatremia. Low serum sodium less than 135 millimoles per liter is considered hyponatremia. Rarely symptomatic in general practice, may present with signs of water excess like confusion, fits, increased BP, cardiac failure, edema, anorexia, nausea, muscle weakness. Causes are in table 1, 13.1, management, treat the cause. If unwell, admit for investigation. Hypernatremia. Excess sodium more than 145 millimoles per liter, rare in general practice. Presentation, thirst. So when there is excess sodium, there will be thirst, confusion, coma, fits, signs of dehydration. Reduction in dry skin, dehydration like dry skin, reduction in skin turgor, postural hypotension, oliguria if water is deficient. So causes are mentioned in table 13.1. Management, admit for investigation. Glycosuria. Page 312 we have already read. Proteinuria. Excess protein in the urine, risk factor for renal disease and CVD. So proteinuria is a risk factor for renal disease and CVD. That's why it's also used in the classification of CKD, and it's a risk factor for cerebrovascular disease or coronary vascular disease. Usually renal in origin. Urine dipsticks are not sensitive for low levels of proteinuria or albuminuria. If proteinuria or dipstick, exclude a UTI and repeat the test. If there is persistent proteinuria, check the dipstick for hematuria, albumin creatinine ratio or protein creatinine ratio, and serum creatinine and blood pressure. So if there is a proteinuria on dipstick, you need to first exclude the UTI, do a repeat test, and if there is still persistent proteinuria, then you do check for hematuria, albumin creatinine ratio, and serum creatinine and blood pressure. Causes of altered serum electrolytes, causes of raised potassium or hyperkalemia more than 5 millimoles per liter. Renal failure, drugs like ACE inhibitors and excess potassium therapy. Potassium sparing diuretics, Addison's disease, hyperkalemia, metabolic acidosis, like diabetes mellitus, as in diabetes mellitus, artifact hemolyzed sample, there will be hyperkalemia. This table only represents causes. Reduction in potassium or low potassium levels less than 3.5. This could be due to diuretics, Cushing syndrome or steroids, vomiting or diarrhea, Conn's syndrome, villus adenoma of the rectum, purgative or licorice abuse, intestinal fistula, renal tubular failure, hypokalemic periodic paralysis, intermittent weakness lasting less than 72 hours. Raised sodium or hyperkalemia, fluid loss without water replacement. Example like in diarrhea, vomiting, burns, diabetes insipidus, suspected large urine volume, osmotic diuresis, primary hyperaldosteronism, suspect if there is increase in BP and decrease in potassium and alkalosis, along with hypernatremia. So along with hypernatremia, if there is hypokalemia and then alkalosis and raised BP, then suspect primary hyperaldosteronism. Sodium less than 135 millimoles per liter. Drugs, especially antidepressants, SSRIs, most common, or diuretics. Okay, drugs like SSRIs or diuretics, thiazide diuretics cause hyponatremia, and renal failure or nephrotic syndrome gut, diarrhea or vomiting, fistula, rectal villus adenoma, small bowel obstruction, endocrine causes like SIAD, syndrome of inappropriate ADH secretion, severe hypothyroidism, Addison's disease, glucocorticoid deficiency, cardiac failure, cirrhosis, cystic fibrosis, heat exposure, water overload, example polydipsia. So the cause of reduction in sodium or hyponatremia can be hypovolemic hyponatremia, hypervolemic hyponatremia or euvolemic. So these are the causes. Postural orthostatic proteinuria, 2 to 5% of the adolescents have postural or orthostatic proteinuria. Rare in more than 30 years age, proteinuria disappears on the early morning sample. No long-term effects are present. Urine ACR and PCR. Check using laboratory urine sample if persistent proteinuria on a dipstick or annually for all patients with diabetes or eGFR is less than 60 milliliters per minute per 1.73 meter square. If initial result is abnormal and an ACR is less than 70 milligrams per millimole, confirm with an early morning sample. Definitions: microalbuminuria, ACR more than 2.5 millimoles in males or more than 3.5 millimoles in females. Albumin concentration more than 20 milligrams per liter. Proteinuria, albumin creatinine ratio more than 30 milligrams per millimoles or albumin concentration more than 200 milligrams per liter. Use ACR in preference to protein creatinine ratio in most patients who are most sensitive to low levels of proteinuria. Use PCR in preference to ACR if high levels of proteinuria is present in children less than 18 years and in pregnant women. So when are you supposed to use a protein creatinine ratio in preference to albumin creatinine ratio? If high levels of proteinuria is present in children less than 18 years and in pregnant women. ACR and risk of adverse outcomes. A patient without diabetes, consider proteinuria to be clinically significant if ACR is more than 30 milligrams per millimoles, approximately equivalent to PCR more than 50 milligrams per millimoles, or a urine protein excretion of more than 0.5 grams per 24 hours. In patients with diabetes, consider microalbuminuria to be clinically significant if ACR is more than 3, that is 2.5 milligrams per millimoles or 3.5 milligrams per millimoles in females. So the cutoff is decreased when you are diabetic. Those without diabetic, more than 30 is considered significant. Page number 410, estimating renal function. Estimating renal function, direct measure of glomerular filtration rate, GFR, using a 24-hour plasma or urinary clearance is most accurate, but is time consuming and difficult in practice. Instead, other methods are often used to estimate GFR. Renal function decreases with age, 1 ml per minute per year, more than 40 years. Always assume a degree of renal impairment in all patients more than 75. Urine albumin creatinine ratio, page 409. Estimated glomerular filtration rate, method of calculation of renal function based on serum creatinine levels. Various equations exist, but in the UK, laboratories report eGFR using chronic kidney disease epidemiology collaboration formula. Okay, this is a different equation. Chronic kidney disease epidemiology collaboration CKD EPI formula. This is adjusted for body surface area using age and sex and ethnicity. Adjusted for body surface area and uses age, sex into 1.018 if it's a female and ethnicity into 1.159 if Afro-Caribbean origin as variables. age, sex and ethnicity, and body surface area. Limitations of EGFR calculation. Do not use if rapidly changing renal function or AKI. May be affected by some drugs like trimethoprim, dependent on muscle mass and diet. Overestimations of EGFR. If elderly, low protein. If the patient is elderly, he is having a low protein diet, amputee, muscle wasting disorder, example myasthenia gravis, late stage muscular dystrophy. The formula overestimates the EGFR and underestimates EGFR if there is a high muscle mass like high level of sport or bodybuilder, high protein diet, example taking protein supplements, muscle breakdown, example after heavy exercise, myositis, muscular dystrophy. So this underestimates the GFR. Interpretation of EGFR. Table 13.2 and figure 13.1. EGFR and cystatin C method. For calculating EGFR using blood cystatin C levels instead of creatinine. Consider at initial diagnosis if standard EGFR using creatinine is 45 to 59 milliliters per minute per 1.73 meter square sustained for more than 90 days and there is no proteinuria or ACR is less than 3 milligram per millimole or other marker of kidney disease is present. Under these circumstances, do not diagnose CKD if EGFR cystatin C is more than 60 milliliters per minute per 1.73 meter square. So, at the initial diagnosis of chronic kidney disease, so if you used this method, CKD EPI formula for measurement of EGFR and you have found it between 145 and 59, then you can use blood cystatin C levels instead of creatinine for EGFR. And then after standard GFR is this sustained for more than 90 days. So after 2 readings of EGFR 45 to 59 with the standard formula, you have to recheck whether the patient is really having a reduction in GFR by checking with cystatin C calculation. No protein and there is no proteinuria in that patient or other marker of kidney disease is not there, but only GFR is reduced. Then you recheck using cystatin C. And under these circumstances, do not diagnose CKD if EGFR with cystatin is more than 60 ml per minute per 1.73 meter square. Interpret EGFR cystatin C with caution if uncontrolled thyroid disease is present. A falsely increased with hypothyroidism and decreased with hyperthyroidism. So if patient is having a thyroid disease, cystatin C, EGFR cystatin C should be interpreted with caution, which increases with hypothyroid and decreases with hyperthyroidism. Cockcroft and Gott formula. Preferred method for estimating EGFR if elderly, more than 75 years, high or low BMI, more than 40 kg per meter square or less than 18 kg per meter square, or at extremes of muscle mass, provides an estimate of creatinine clearance. See, because we have said that these variables, like in the elderly people, when there is high or low body mass index, and when there are extreme of muscle mass like bodybuilders and very lean people, then the initial formula was not suitable to measure GFR because there can be wrongly high or wrongly low readings. In that case, you need to use the Cockcroft and Gott formula, which is there in box 13.1. So it provides an estimate of creatinine clearance. Box 13.1. Formula for calculating creatinine clearance. Creatinine clearance is equal to 140 minus age in years into weight in kgs divided by serum creatinine in micromoles per liter into 1.23 if it's a female or 1.04 if it's a female. Use ideal body weight where fat may be a major contributor to the body mass. Use actual body weight if less than ideal body weight or high BMI is due to increase in muscle bulk. So in case there is more fat content, then use ideal body weight for the age and height of that patient. And if actual body weight is less than the ideal body weight or high, or the BMI is very high, is due to increase in muscle bulk, then you can use the actual body weight. Ideal body weight in kgs is equal to 50 in males or 45 in females plus 0.91 into height in centimeters minus 152.4. This is the ideal body weight. Estimating renal function, interpretation of EGFR results. EGFR in milliliters per minute, 1.73 meters square. If EGFR is more than 90, normal EGFR, if serum creatinine is high, more than 20%, may indicate a significant reduction in renal function. 60 to 90 does not indicate CKD unless other markers of kidney damage are present. Example, ACR more than 3 milligrams per millimole, persistent microscopic hematuria or structural abnormalities like polycystic kidneys. 45 to 59, this is stage 3A, may indicate CKD if proteinuria or other markers of kidney disease are present. If no proteinuria, ACR is less than 3 milligrams per millimoles and no other markers of kidney disease, consider checking EGFR with cystatin C. Yeah, that we have checked. We have read about this. And if it is less than 45 on two readings 90 days apart, indicates CKD. So this one is classification of CKD using EGFR and ACR categories. Yeah. So grade 1. This scale is GFR categories, description and range. This one is persistent albuminuria categories, description and range. So G1 normal or high, more than 90. A1 normal to mildly increase, less than 30 milligrams of albumin or less than 3 milligrams per millimoles, less than 30 milligrams per gram or less than 3 milligrams per millimole. Then there is no kidney disease. Also G2 function is mild, GFR is mildly decreased. So this one is category 60 to 90, 60 to 89. This is GFR and again A1, that is no proteinuria. Then it is not CKD. But even if when stage G1 or G2 and there is A2, that is 300 to 30 to 300 milligrams per gram of protein or 3 to 30 milligrams per millimoles of albumin, in that case it is considered as green is low risk, yellow is moderate risk, so this is moderate risk of CKD. Whereas if G1 and G2 is in G1 and G2 category, if there is severely increased proteinuria, then it is considered orange is high risk for CKD. So till 3A and 3B, A1, it is high risk. Similarly, if it is G4, that is GFR is markedly severely decreased 15 to 29 and any category of albumin will be categorized as chronic kidney disease. So we are going to next topic, presentation of renal disease. Renal disease may present to the GP with hematuria, proteinuria, decrease in renal function, outflow tract obstruction, hypertension, UTI pyelonephritis, nephrotic syndrome, nephritic syndrome, acute kidney disease or acute kidney injury, reduction in renal function by hours or over hours or days, plus or minus oliguria or anuria, investigation for AKI by checking the serum creatinine and comparing with baseline if acutely unwell or any of the following factors apply. Age more than 65 years, heart failure, sepsis, past history of acute kidney injury, liver disease or diabetes. CKD, especially if eGFR is usually less than 60 milliliters per minute. Hypovolemia, example when there is diarrhea, vomiting, diuretics, fever. Disability that may limit the access to fluids, example cognitive impairment or neurological conditions. Potentially nephrotoxic drugs in the past week like NSAIDs, ACE inhibitors, ARBs, diuretics, iodinated contrast agent. These are all nephrotoxic. Oliguria, urine output less than 0.5 ml per kg per hour. History of or condition predisposing to urological obstruction. Diagnostic criteria for AKI. Increase in serum creatinine of more than 26 micromoles per liter in less than 48 hours. Increase in 50% in increase in serum creatinine known or presumed to have occurred in less than 7 days. Reduction in urine output to less than 0.5 ml per kg per hour for more than 6 hours in adults and more than 8 hours in children or young people. To more than 25% reduction in eGFR in children or young people in less than 7 days. These are all the diagnostic criteria of acute kidney injury. Management. If AKI is suspected, admit to hospital as an emergency. Follow-up. Monitor for development of progression of CKD for at least 2 or 3 years after AKI, even if creatinine has returned to baseline. Prevention. Consider sick day rules. If a patient is unwell with fever, sweat, or rigors, or vomiting or diarrhea, unless minor, stop the ACE inhibitors and ARBs, example losartan, candesartan, ramipril, lisinopril. Stop the NSAIDs, example ibuprofen and naproxen. Stop the diuretics like furosemide, bumetanide, dydrofumetazide, and metformin also. Increases the risk of lactic acidosis when you are dehydrated. So you need to stop these drugs unless it's a minor illness for preventing acute kidney injury. Chronic kidney disease. Page 414, we'll read nephrotic syndrome. Nephrotic syndrome is characterized by proteinuria, hypoalbuminemia, and edema, often associated with increasing cholesterol. Causes are minimal change disease, minimal change glomerulonephritis, 90% of children and 90% in children and 30% in adults. Membranous glomerulonephritis, focal segmental glomerulonephritis, membranoproliferative glomerulonephritis, and diabetes, amyloid, neoplasia, endocarditis, polyarteritis nodosa, sickle cell disease, SLE, malaria, drugs like penicillamine and gold. Presentation of nephrotic syndrome, swelling of the eyelids and face, ascites, peripheral edema, urine froth due to protein. So frothing of urine due to protein. Patient has peripheral edema and ascites, swelling of the eyelids and face. Nephrotic crisis, unwell with edema. The patient is unwell with edema, anorexia, vomiting, pleural effusions and muscle wasting. Investigations. Urine albumin creatinine ratio is more than 220 milligrams per millimole. microscopy for red blood cells and CAS, blood test, urea and electrolytes, creatinine, eGFR calculation, albumin less than 25 grams per liter, cholesterol, FBC, ESR or CRP. Management. Refer all suspected cases of nephrotic syndrome to renal physician. Complications include thromboembolism, hypercholesterolemia, infections especially pneumococcal infection if persistent nephrotic syndrome offer vaccination. Hypovolemia and renal failure. Loss of specific proteins like transferrin causes hypochromic anemia, which is iron resistant. Nephrotic syndrome. This is nephritic syndrome. Central feature is blood and protein in urine from the glomerular inflammation. Causes are glomerulonephritis may occur after throat, ear or skin infection with group A beta hemolytic streptococci, vasculitis. Features are oliguria, hematuria, proteinuria, fluid retention, increase in BP, uremia and increase in creatinine. Management. Refer suspected cases immediately to renal medicine. Risks: hypertensive encephalopathy, pulmonary edema, acute kidney injury. So nephritic syndrome can predispose to hypertensive encephalopathy, pulmonary edema, acute kidney injury. Prognosis. Excellent in children. In adults, some proteinuria or urine sediment may persist. CKD is rare. Nephrocalcinosis. Deposition of calcium in the kidneys. X-ray calcification may cause symptoms of UTI or renal stones. Cause is medullary hypercalcinosis causes hyperparathyroidism, distal renal tubular acidosis, medullary sponge kidney, idiopathic calciuria, papillary necrosis, oxalosis. Cortical nephrocalcinosis, the cause is serious renal disease or chronic glomerulonephritis. So most of the nephrocalcinosis is due to medullary nephrocalcinosis because of hyperparathyroidism, distal renal tubular acidosis, medullary sponge kidney, idiopathic calciuria, papillary necrosis or oxalosis, anemia and renal disease. Secondary anemia due to reduction in kidney erythropoietin production is universal among people with severe renal disease G4 and G5. Exclude other causes. Recombinant erythropoietin is given if hemoglobin is less than 10.5 grams per deciliter. So this is the threshold. So when do you give erythropoietin in a renal CKD patient grade 4 or grade 5 if hemoglobin is less than 10.5 grams per deciliter? Specific kidney disease 416. Page number 414, chronic kidney disease. A slow reduction in renal function over months or years. Common prevalence. Slow reduction of renal function over months or years is chronic kidney disease. Common is prevalence is 8.5%. This increases with age. Females more than males. Usually asymptomatic. May be associated with increase in BP. In later years may cause nausea, vomiting, anorexia, lethargy, edema, dyspnea, plus or minus itching. Causes of chronic kidney disease: diabetes, hypertension, urinary obstruction, chronic pyelonephritis, nephrotoxic drugs, CBD, increase in calcium, polycystic kidneys, glomerulonephritis, renovascular disease, interstitial nephritis, SLE, amyloid, myeloma, PAN, and acute kidney injury. Classification of CKD. Figure 13.1. We have already seen that classification, right? Both increase in ACR and decrease in GFR associated with increased risk of adverse outcomes, renal failure and CVD. In combination, risk is multiplied. Testing for CKD. Check the eGFR plus ACR in most cases once every year, and if more than one of the following is present: high BP, diabetes, all type 2 diabetes and type 1 diabetes if present more than 5 years, AKI is present, hematuria, CVD, stroke, TIA, ischemic heart disease, heart failure, peripheral vascular disease, structural renal tract disease, recurrent renal calculi or BPH, multisystem disease with potential kidney involvement like SLE, family history of end-stage kidney disease or hereditary kidney disease, if prescribed drugs known to be nephrotoxic, example calcineurin inhibitors like cyclosporin and tacrolimus, lithium and NSAIDs. Repeat the test less than 2 weeks if eGFR is less than 60 ml per minute and no previous test. So you have to repeat a second test in less than 2 weeks. Frequency of CKD monitoring is given in table 13.3. Tailor the frequency of testing to individual according to underlying cause of kidney disease, eGFR, ACR history, comorbidities, general health status, intercurrent illness and changes in drug treatment. Investigations of hematuria 420. Refer for renal ultrasound if, so when do you refer for a renal ultrasound? If eGFR is less than 30 ml per minute in G4 or G5 category, or there is an accelerated progression of CKD, sustained reduction in eGFR more than 25% and a change in eGFR category in less than 12 months, or a sustained reduction in eGFR of more than 15 ml per minute per 1.73 meter square per year. So these are the three criteria suggesting accelerated progression of CKD. So you have to refer for renal ultrasound. If there is reduction in eGFR 25%, if there is a change in eGFR category in less than 12 months, or a sustained reduction in eGFR of more than 15 ml per minute per year. Symptoms of urinary tract obstruction is there. Family history of polycystic kidney disease and patient is aged more than 20 years. You will refer for a renal ultrasound. Frequency of CKD monitoring based on eGFR. So all the categories up to G3A and A2. G3A and A2, it is one time in a year. Category G1 and G2, it is less than one time in a year. Category G1 and G2 A1 and G1 G2 A3 is more than one time in a year. Whereas in G3 A3 it is more than 2 times a year from G3A A3 onwards. G3A So this is the frequency of monitoring based on eGFR and ACR level. So please go through this. Management of CKD. Discuss the causes of CKD, risks, progression of renal disease, increase high BP, CVD, increased mortality and management. Treat reversible causes if possible. Stop or avoid nephrotoxic drugs, example NSAIDs. Consider reduction in dose of other drugs as excretion or metabolism may be impaired. Stop metformin if eGFR is less than 30 ml per minute per 1.73 meter square. So when the patient is in category 4 CKD, you are supposed to stop metformin. Annual review of CVD risk. Check the lipid profile and give lifestyle advice, smoking reduction, weight loss, exercise, alcohol consumption. Treat high BP. Target BP in a CKD patient is less than 140 by 90. And if there is CKD plus diabetes or CKD plus ACR more than 70, aim for a BP reduction of 130 by 80. So The target BPs differ. To target BP should be less than 140 by 90 in any patient with CKD, without albuminuria or without diabetes. And if CKD plus diabetes is present or CKD plus ACR more than 70 milligrams per millimoles, that is category A3, aim for a BP reduction of 130 by 80. Offer AC inhibitor or ARB if CKD plus diabetes plus ACR more than 3 milligrams per millimoles, CKD plus BP plus ACR more than 30 milligrams per millimoles, or CKD plus ACR more than 70 milligrams per millimoles. So offer atorvastatin 20 milligrams nocturnal if reduction in CVD events and death by 20%. So primary prevention of with atorvastatin 20 milligrams decreases the CVD risk in CKD patients and death by 20%. Increase the dose if less than 40% reduction in non-HDL cholesterol is there and eGFR is more than 30 ml per minute. Then you have to increase the dose. If eGFR is less than 30 ml per minute, then seek specialist advice. So until the eGFR is more than 30 ml per minute, you can increase the dose of atorvastatin from 20 to 40 to achieve a desirable reduction in non-HDL cholesterol, that is less than 40% of the baseline, to less than 40% of the baseline. So if the cholesterol control is not adequate and the eGFR is less than 30, then you seek a specialist advice. Offer the folic acid or vitamin B12 supplements if reduction on laboratory testing or poor diet. Refer to a renal physician. So when do you refer to a renal physician? If eGFR is less than 30 ml per minute or ACR is more than 70 milligrams per millimole, unless which is caused by diabetes and already treated, or ACR is more than 30 milligrams per millimole and there is hematuria, unless urgent referral for suspected cancer is indicated. So, and then sustained reduction in eGFR of more than 25% plus change in eGFR category or sustained reduction in eGFR of more than 15 ml per minute in less than 12 months. So less than a year, if any of these three is there, then you have to refer to a renal physician. Poorly controlled BP despite more than 4 antihypertensive drugs, you refer to a renal physician. Known or suspected rare genetic causes of CKD or renal artery stenosis. If renal outflow obstruction, refer to urology. So you have to decide whether you want to refer to a renal physician or a urologist. So if obstructive causes are there, then refer to urology. Dialysis. Start if eGFR is less than 10 to 15% of the normal. Needed lifelong unless transplant becomes available. Refer to patient's renal unit if any problems. Hemodialysis. So when do you start dialysis? Start if eGFR is less than 10 to 15% of the normal. Needed lifelong unless transplant becomes available. Refer the patient to renal unit if any problems are there. Hemodialysis. Blood flows opposite dialysis fluid and substances are cleared along a concentration gradient across a semi-permeable membrane. Problems are pulmonary edema, infection, hepatitis and bacteria, UND, urea electrolyte imbalance, high blood pressure or low blood pressure, problems with vascular access, dialysis, arthropathy, especially the shoulders and the wrist, aluminum toxicity and time. Continuous ambulatory peritoneal dialysis. Permanent catheter is inserted into the peritoneum via subcutaneous tunnel. Dialysis fluid is introduced and kept in the peritoneum, changed up to 5 times a day at home. The patient is not tied to a dialysis machine. Problems are emergency referral, peritonitis, catheter blockage and other problems. Increase in weight, poor diabetes control, pleural effusion and leakage. Of course, because when you're putting the dialysis fluid in the peritoneum, there will be increase in weight and then poor diabetic control, pleural effusion and leakage. Renal transplantation, usually cited in an iliac fossa. 5-year graft survival. Okay, usually the transplanted kidney is cited in an iliac fossa and not in the retroperitoneum. 5-year graft survival is more than 88% for adults. Closer genetic matches increases the survival rates. Problems are there might be rejection, persistent high BP, atherosclerosis, 5 times more risk of MI death, and increase in cholesterol, high cholesterol. Renal artery stenosis at 3 to 9 months post-op, obstruction at the ureteric anastomosis, cyclosporin-induced nephropathy, infection secondary to immunosuppression, malignancy from immunosuppressants. Specific kidney diseases, interstitial nephritis, important cause of renal failure associated with inflammatory cell infiltration of the renal interstitium or tubules. Causes are acute interstitial nephritis, idiosyncratic reaction to drugs, penicillin, NSAIDs, furosemide, or infection, staphylococcus or streptococcus. So causes are acute interstitial nephritis causes and chronic interstitial nephritis causes. Acute interstitial nephritis due to idiosyncratic reaction to drugs like penicillins, NSAIDs, furosemide, or infection like staphylococcus or streptococcus. Chronic interstitial nephritis causes are idiopathic, most common cause, drugs, sickle cell disease, analgesic nephropathy. Analgesic nephropathy is a cause of interstitial nephritis. Presentation and prognosis. It presents with acute kidney injury or chronic kidney injury, fever, arthralgia, eosinophilia. Patients with acute kidney injury have good prognosis. Those with chronic kidney disease tend to gradual deterioration over time. Diabetic nephropathy. 325. Analgesic nephropathy caused by prolonged use of analgesics including NSAIDs. Patients with an interstitial nephritis like picture associated with increased incidence of UTI. Carcinoma of the renal pelvis is rare complication. Investigate promptly if the patient develops hematuria. Glomerulonephritis. Types and presentation, table 13.4. Refer all suspected cases urgently to a renal physician. If you are suspecting glomerulonephritis, refer to a renal physician. So glomerulonephritis can present with hematuria or edema or high BP, either with nephrotic syndrome or nephritic syndrome. Terminology. Focal, some glomerulus is affected, diffuse, all glomerulus is affected, segmental, part of each glomerulus is affected, global, all of each glomerulus is affected. Chronic pyelonephritis, presence as CKD or one of its complications probably arises from UTIs, vesicoureteric reflux, and a consequence of renal scarring in childhood. Refer to a renal physician. Types of glomerulonephritis. Type. Minimal change, most common in children, presence with nephrotic syndrome, membranous, 30% adult nephrotic syndrome, underlying malignancy in 10% of the adults, 1 in 3 enter remission, 1 in 3 are proteinuric, 1 in 3 progress to end-stage renal disease. Focal segmental glomerulonephritis, proteinuria or nephrotic syndrome is the presentation, may be associated with heroin misuse, more than 50% progress to CKD. Membranoproliferative, 50% as nephrotic syndrome. Associations are endocarditis, C3 nephritic factor, autoantibody, hepatitis C, measles. So hepatitis C will cause membranoproliferative glomerulonephritis. Proliferative glomerulonephritis, presence with nephritic syndrome, classically seen 2 weeks after streptococcal infection. Prognosis is excellent. IgA disease or Berger's disease. Causes: recurrent hematuria in young man, Similar to picture seen in Henoch-Schönlein purpura, more than 30% progress to ESRD. Rapidly progressive crescentic glomerulonephritis. Presents with hematuria and oliguria and raised BP, acute kidney injury. Vigorous treatment may preserve the renal function. Causes are of RPGM are anti-glomerular basement membrane disease, good pastures disease, Wegener's granulomatosis, and Henoch-Schönlein purpura. All these conditions cause RPGN or rapidly progressive glomerulonephritis presenting with hematuria and oliguria, raised BP, that is nephritic picture. Hemolytic uremic syndrome. Most common cause of AKI in children, acute kidney injury in children, usually follows gastroenteritis due to E. coli toxin. Have a high index of suspicion in any child with bloody diarrhea. Occasionally occurs without diarrhea. Other features are dehydration, oliguria, though may be polyuria, proteinuria or hematuria, hematological features like anemia, thrombocytopenia, and purpura. CNS symptoms: irritability, drowsiness, ataxia, and coma. Increased BP associated with non-diarrheal disease. Management: admit for specialist care. Often include dialysis. If associated with diarrheal illness, more than 80% make full recovery. Mortality is 1.8%. Poor prognostic indicators are age more than 5 years at onset, dialysis for more than 2 weeks. Disease in the absence of diarrhea has poorer prognosis. So that's all for today. Tomorrow we will continue starting adult polycystic kidney disease, page number 417. Thank you. Have a good day.